Okay, so this is the last case we're going to do. A 33-year-old guy seen in the eye clinic for 10 years. Has some history of recurrent ocular inflammation. Described as occurring 2 or 3 times a year. And he's having a current attack for several weeks. The ophthalmologist noted in his referral note to the rheumatologist, he's had an extensive workup in the past for sarcoid, syphilis, and multiple conditions, which had all been negative. But he is referred because he has this kind of history of recurrent joint pain, kind of elbows, wrists, ankles. But he clearly describes what he describes as swelling of his knees. But he's never had any back pain whatsoever. So recurrent ocular inflammation, some description in the setting of a kind of a nondescript polyarthritis. So actually scribing from the Cleveland Clinic redacted ophthalmology note, which are only interpretable by ophthalmologists since they use a litany of abbreviations which are virtually uninterpretable by all, and Doug can read both sides of these. I think the salient features here is that on the left he's got some cells and a trace flare. He's got some posterior synechiae, 2+ nuclear sclerosis. You can explain this ERM thing to us in a minute. But the background material here is that a number of tests are ordered, including B27, syphilis again, screening for TB, ACE, chest X-ray, and some prednisone. But Doug, could you just interpret this note here for us, and what do you think that I'm sure Dr. Srivastava, who you know, is thinking about?
So the first thing is that the cell and flare in the anterior chamber is indicative of an anterior uveitis, and he has a mildly active anterior uveitis in both eyes. The posterior synechiae are adhesions between the iris and the lens, and they show evidence of previous anterior segment inflammation inside the eye. The left eye has a moderate cataract, which was probably related to the inflammation given his age. And an epiretinal membrane, which is what an ERM is a thin membrane. It's a fibrotic tissue over the surface of the retina that's associated, has many causes, but is common in patients with inflammation. He also has, the quality of the printing is difficult, but he's got punched out spots in the retina with some vitreous exudates. And that's important because now it looks like he has really a pan-uveitis on the left because he's got evidence of inflammation in both the anterior chamber, the vitreous, and the retina. And that changes what we think about when we think about the uveitis, which type of uveitis it is.
So
can you amplify on that?
Sure. This extends from someone with just relapsing anterior uveitis to something more.
Yeah. So look, if the guy's got joint pains, and you might in a guy with joint pains and iritis be thinking of a reactive arthritis. Okay. The problem is that the arthritis, that the uveitis of reactive arthritis, and all B27, is a recurrent acute unilateral or unilateral alternating anterior uveitis. Now, what do I mean by that? Well, it's episodic, it's recurrent and acute. You have periods where there's no active disease off all treatment. It's anterior, so it's only in the front of the eye. And it's unilateral or unilateral alternating, which means that it's one eye at a time, and either one eye is only affected or one eye at a time, but either may be affected, but it's not bilateral simultaneous. This guy's got bilateral simultaneous. Right now, he's got evidence of inflammation in the anterior chamber in both eyes, plus a vitritis. So that would make it very unusual for a B27-associated disease. And the punched out atrophic spots, at least described, make you think of a disease called multifocal choroiditis with panuveitis, which is completely unassociated with any systemic disease and is an eye-limited presumed autoimmune disorder.
Okay.
Fascinating. Now, there is a certain paradigm whereby it is said that the uveitis associated with ankylosing spondylitis is that classic acute unilateral, but with psoriatic arthritis can be bilateral.
Yeah, so
And-
psoriatic arthritis can be, and psoriatic arthritis is more often to evolve into a chronic. So with spondylitis and reactive arthritis, about 90 to 95% of the time, they stay as a recurrent acute unilateral alternating. And about 5 to 10% of the time, after a crescendo pattern, in other words, the attacks become more and more frequent, they slide into a chronic disease, much like occasionally reactive arthritis will slide into a chronic disease. Psoriatics can have chronic uveitis more often than the other spondylitis-associated uveitis.
And the fact that he already has some cataract, how long might it have taken for this to develop?
You know, how long has he had his uveitis?
10 years.
10 years, yeah.
Oh, that long, okay.
Yeah.
Yeah, it's been going off and on for years, but it's usually fairly self-limited.
Okay.
Getting
And
worse.
So do you have more information? I mean, has it been a recurrent acute disease?
Well, all we have is the history, and this is the initial intake at the call on it, and so you're reading the tea leaves the way that our guy's reading the tea leaves.
Yeah. So we do have, I mean, it would be helpful in terms of deciding which uveitic disease this is.
Sure.
To have some better information
Okay.
about the past.
But prednisone would not be an unreasonable gambit at this juncture, at this time?
Well, if you thought he had multifocal choroiditis with panuveitis, the available information suggests that on a chronic basis, you require more than 10 milligrams a day of prednisone to control the process. And so if I thought that was the diagnosis, he'd get started on prednisone and an immunosuppressive agent such as mycophenolate.
Okay. So,
But we still haven't dealt with what's going on with the joints.
I'm going backwards here. All right, so he has a negative family history. He has no symptoms of GI disease and no signs of psoriasis. He does relate this 10-year history of back pain. It's non-traumatic. It occasionally wakes him up at night, but it doesn't really reproducibly respond to exercise. This is not classic inflammatory back pain. It has some features of it. I can see the wheel spinning in Dr. Weisman's head. His worst problem, the worst problem that he has is this recurrent knee pain associated with some significant swelling. I apologize for the typos. He takes some ibuprofen, gets a little bit of relief. And he states, though, when he gets this prednisone, which he's got 2 or 3 times a year, that these joints, he feels pretty damn good. And today you do a complete exam of him, Schober's, examine all of his joints, and it's unremarkable. Laboratory comes back. His ACE is normal. He is B27 negative, as Doug was proffering. His acute phase reactants are pretty rock normal, but you know, he's just been recently on prednisone. ANA is negative, rheumatoid factor is negative. So, I'm giving you, okay. So, I mean,
don't take it away.
All right, what would you like to do here? I heard MRI of his spine, but I mean, so, okay, Michael, give us up until this time, because I have a little bit of data to share with you, and it's actually not remarkable, but where are you going here from your end?
Well, I think that the comments earlier about B27 iritis are right on. It's rare to see it like this, although we think more of Crohn's as an underlying diagnosis when you see bilateral chronic disease. If this were a teenager or younger, what would you think? What's our ophthalmologist think if this were a teenager?
Even in a young adult, certainly you can see more often a chronic inflammatory process in a patient with Crohn's. And the other thing which I didn't see in the lab data, which you do have to at least worry about with an intermediate or posterior uveitis, is Lyme disease, because it certainly causes it. And so I live across the Sound from Lyme, Connecticut, so I have to worry about it.
10 years?
10 years? No, I agree. But you at least have to think of it.
Yeah, sure.
When a patient presents.
The probability of this being spondylitis is very remote. I'm not sure I'd even bother with any imaging studies.
Okay, his plain films were pristine. But, you know, I mean, on a good day, you might interpret those back symptoms as, inflammatory back pain, wouldn't you?
You would, but I wouldn't.
You know, well, I did. I like the fact that his back pain felt so good on prednisone.
Oh, that's wonderful, but I'm glad I don't send my patients to one of these multidisciplinary.
All right, so anyway,
nobody seems to make a diagnosis with this clinic.
Well, he is. It's really cruel. Very cruel. Next time you call me for anything, you're going to get hung up on. So his plain films are negative, and these are the only slices that show anything on here. And you know, you're now the guy on the new criteria for the
Yeah, we heard all that
back,
stuff.
and I can't even understand what you guys are talking about. So what are we looking at here? Would you interpret? We have a stir image. We have a T1
yellow
image.
arrow.
Does this do anything to you?
We call that a ditzel. You know,
So
which
like
is
in the brain, that's a UBL,
yeah,
right?
that's all that is. And 10 years of back pain and a negative plain X-ray in somebody in their 30s. What are you spending this kind of money for? I mean, the clinic is doing pretty well.
Yeah, well, that's a good thing. So our musculoskeletal radiologist agrees with you 100%. Said that this is, she walked by this. Said this is nothing. But not everybody walked by it. So, but at any rate. So okay. So we have a guy with relapsing uveitis and a moderately impressive history. He's a 33-year-old guy with you know, migratory polyarthralgia and quasi convincing history of some intermittent knee swelling. I mean, are we going to call it anything? Is this reactive arthritis? Is this just?
Of course not.
All right.
I mean, don't you guys know how to do a physical exam after 10 years? Everything is normal?
I guess he's perfectly healthy. I'm sending him to Cedars-Sinai. There's nothing wrong with him. So
I think this is some kind of eye disease.
Okay.
That's what I'm thinking.
All right.
And if not, I would do
You
a
kick him
Crohn's
out of the
workup.
guy. He doesn't even
Yeah,
get
I
admitted
don't
to
think
the
so.
Leeds musculoskeletal
No,
clinic.
I don't think so.
He has no
This is-
abnormal lab test.
This is eye disease, so,
Well,
What's his racial group?
yeah.
I saw yours his picture right
Well, I know.
there.
Is he Mediterranean origin?
Yeah, he's got a little Eastern European.
Yeah.
He's in Cleveland.
Yeah, he's, you know,
What do you expect?
Slovenian.
Yeah,
guy
he's-
from 55th and.
So crude.
Up.
so
I think you've made really good points about the differential diagnosis here and practically what to do and practically what not to do. Given the fact that his exam's negative, he's had 10 years of symptoms, everybody gets better with a little bit of prednisone, and there's nothing to show for it anywhere. So even if it was true and you found a golden scroll underneath the thing that said what he had, you wouldn't treat it anyway.
All right, so,
Okay.
but he does need his eyes treated.
That's
and
right.
He's got bad eye disease.
And he needs that, and the whole issue then is, do you use immunosuppressive drugs in these eye diseases? Or do you use perhaps a biologic drug? I mean, this guy's got really bad disease. He's got complications from steroids already in his eyes. So this is a tough case.
Let me feed
that,
you-
That cataract's probably more related to the inflammation than steroids.
Yeah. I'll feed you a little bit more information. So he underwent cataract removal, and he had an insertion of a dexamethasone intravitreal implant. The rheumatologist, who apparently knew nothing, according to Dr. Weisman, started adalimumab and monotherapy, which was, just, the ophthalmologist was not totally opposed to this because of this decade of relapsing thing. And, geez, amazingly, he felt pretty great on this adalimumab. But 2 months later, he had some recurrence of, on adalimumab, monotherapy. His steroids had been tapered. He now has increase in eye symptoms with some trace cells in the anterior chamber on the left. And they collectively agreed to increase his adalimumab from every other week to weekly. And then 4 weeks later, after weekly adalimumab, he now is flaring with bilateral disease. So I'm going to take the lead here. Doug, what do we do, man?
So, it's well, first, you got 3 choices. You can look for an infection. You can look for something really exotic like Whipple's. You can do a diagnostic vitrectomy. Is this, how old is he?
33.
33. Unlikely to be lymphoma. We do get lymphoma in the elderly population that looks like a uveitis, particularly one that's refractory to appropriate therapy. Or you can change you can either change or increase your anti-inflammatory medications. Those are your three options at this point.
Okay, let me feed you a little bit more information here. So those are the next thoughts. So the team opted to add azathioprine, antimetabolite, 2 milligrams per kilogram per day, which he tolerated quite well. 3 months later, he returns flaring again, and now has increased intraocular pressure on that side. Each time he's flaring, they're treating him topically and systemically with these pulsing of steroids, and they're planning to do some kind of glaucoma surgery, and I copied this verbatim. I did Wikipedia, the Ahmed tube shunt OD, but I actually forget what it is. So where are these guys heading here with this guy?
Down the drain. He's not responding. I mean, you can try switching to your treatments.
Is there salvage therapy for people on TNFs and antimetabolites and
Sure.
that are steroid dependent? What are your...
So what you could put in is the fluocinolone acetonide implant, which is a implant that lasts 3 years, and in a randomized comparative trial was slightly more effective than systemic corticosteroids and immunosuppressive drugs. So that certainly is an option, is to put in an implant in the eye. The problem with the implants are that there's a guarantee of cataract at 3 years, cataract surgery at 3 years, and a 40% chance of glaucoma surgery. But the flip side is if he's already had his glaucoma surgery, usually you've dealt with the problem.
You had mentioned mycophenolate before. Is there any point in that at this point, or you think he's getting pretty immunosuppressed with what he's been getting?
So the available data, which are not randomized, but which are large case series, suggest that azathioprine and mycophenolate are about equal in efficacy for uveitis, but azathioprine has a higher rate of discontinuation for side effects. So my personal preference is mycophenolate, but azathioprine probably works about as well.
I don't know about the audience, and I don't know about you guys up here, but we are frequently and routinely, and we like to be drawn into these cases, and we co-manage them in our group. So just
Len, what about checking? It sounds like he's breaking through adalimumab, so why not check drug and antibody levels of adalimumab to perhaps guide therapy? You
know, JP, you're raising an issue here that you know, is kind of another elephant in the room in rheumatology. We know about immunogenicity with infliximab, and we certainly know about immunogenicity with adalimumab in RA trials, but you know, this is not something that is widely talked about. Paul, what do you guys do with this immunogenicity question?
We never measure antibodies because unless they're affecting drug levels, it's irrelevant.
So are you measuring drug levels?
The new biosimilar data shows that virtually everybody has antibodies.
Yes. Do you measure drug levels?
We do sometimes, rarely, but he's only had, how long has he had?
He's been on a few months now.
Has he? Okay.
Yeah.
And he's on steroids and azathioprine, but so he's be unlucky.
JP?
Well, you know, what if I told you that on weekly adalimumab you measure his drug level is 0 and his antibody level is sky high? Wouldn't that affect your decision making?
Yeah.
If his drug level was normal.
Low.
Was 0. Undetectable drug and sky high antibody.
Why would the antibody, if he was weekly adalimumab and his drug level was unmeasurable, that's the important bit, not the antibodies.
Okay.
So,
well, I guess, you know, in our literature, there's increasing evidence of you know, breaking people down into those who've developed immunogenicity, those who are underdosed, and those who are refractory with good-looking drug levels and low-level antibodies. So we're applying that more and more in decision-making with whether to switch within anti-TNF family drugs or whether to switch out of class to alternative therapies.
JP, you're absolutely right on, and a lot of us are thinking more and more about this issue with adalimumab. But you're getting some uncertainty on the panel about whether or not there's even a rationale for adalimumab here. We aren't sure where we are, and so even if he did have 0 levels, we don't know what that means.
Okay, I'll finish this case rapidly. So the where's our, do we have any next steps, or that is the next step? I guess we did finish this case rapidly. So, you know, this is real life, and this is actually the way that I took this off the chart. It was shared with me by one of my colleagues, Rula Hajali. And so, the next steps are being determined as we go. I think that ophthalmologists, we co-manage many patients with TNF inhibitors. We use some of the same principles of induction and maintenance. I think this would be early on to think that immunogenicity was the problem. It's probably a refractory disease or a wrong target, but I really appreciate Doug Jabs' comments here. I think we've learned a lot. I want to thank Abrar Qureshi for some salient and clarion comments about the skin disease. I want to thank JP for throwing in on several of these cases, and the ever treadmilling Dr. Michael Roizen. I want to thank him for everything that he's thrown in. But most of all, I want to thank these 3 guys. They've done a great job, and thank you all for coming.